Well, good afternoon, everybody, and welcome to the fourth of 6 sessions in the Providing Healthcare in a Pandemic webinar series. As you know, this series was developed to support our healthcare and service providers who have faced a host of challenges due to the COVID-19 pandemic. Today's session topic is COVID-19 response in long-term care facilities. And I'm going to go ahead and share. So I'm Lisa Green, and I'm a program coordinator for the Western New York Rural Area Health Education Center, or R-AHEC for short. And before we meet our presenter, there's just a few things to know as usual. The chat box is open, so please introduce yourselves there. If you have any questions during the presentation, please don't hesitate to type them into the chat, and we'll make sure that they are answered. I know from experience that Dr. Collins would rather answer questions as they arrive and as they are relevant, so don't worry about interrupting his presentation. Also, feel free to leave the webinar at any time. If you do have to leave early, remember that there are recordings of all sessions on our website at www.r-ahec.org within a day or so of all of our live sessions. And don't forget to visit our website and fill out an evaluation using the link that's provided. That link is also in your Zoom invite, and it will be in your follow-up Zoom or your follow-up email as well. So you can connect with the evaluation page that way. And if you have any follow-up questions, if you'd like to contact one of us at a later time, my email is lgreen@r-ahec.org. So our presenter today will be discussing relevant COVID-19 statistics, transmission information, PPE, long-term care considerations and strategies, and his name is Dr. Greg Collins. How are you today, Greg?
Good, thank you. And yourself?
I'm very well, thanks. Dr. Collins is the medical director and attending physician for the Wyoming County Skilled Nursing Facility. The skilled nursing facility has 135 residents and is located in a rural community of 40,000. He received his Master's of Public Health degree from University of Massachusetts, his medical degree from the Chicago College of Osteopathic Medicine, and he completed his residency in family medicine at the University of Rochester. He is board certified in the subspecialty of addiction medicine and is certified by the ABPLM as a long-term care medical director. Dr. Collins maintains an active clinical practice as well, which includes medication-assisted addiction treatment, emergency medicine, geriatrics, occupational medicine, and correctional health services. So welcome, Dr. Collins, and you can share your slides whenever.
All right, let me give that a try. Okay, good. All right, so I unfortunately I'm not on camera today as I am at a computer screen without a camera in it, believe it or not. But I wanted to welcome everybody, appreciate everyone listening in today to talk about this timely topic. I'm involved directly with the Wyoming County Skilled Nursing Facility as their medical director and also an attending physician for the residents. And I'm also the health commissioner for the county, so I've been intimately involved in the COVID-19 pandemic response as well. Let me see. There we go. Okay, so looking at this from the perspective of the long-term care environment in the specifically the skilled nursing facilities, it's obviously been a major issue from a COVID standpoint. I really just wanted to go through, talk about some of the different statistics related to the COVID issue and long-term care, some of what's happened, a little bit of review about the virus itself and transmissibility, and then some of the topics specific to managing this issue in the long-term care setting that have been a significant challenge. So the country's introduction to COVID really came to the forefront back the end of last February, the beginning of March. There'd been, I think, an initial positive case in California in a traveler, but after that, nobody was too worried about anything at the time until we heard about this thing that happened in the state of Washington in King County, where a nursing facility ended up getting infected. They had a resident positive in the end of February, and then subsequently went on to have 129 total cases involving 81 residents, 34 staff, and 23 deaths. And I think this was really an eye opener for many of us, though at that time it was still isolated in Washington and a few sporadic cases, but not major issue over here in the Northeast. But it was kind of foretelling what we were going to be facing and continue to deal with currently. And speaks to the virus itself that has turned out to be very relentless and unforgiving in its progress. So, from that initial experience, we have now had, as everyone knows, multiple nursing homes that have been impacted by this and continue to be a number here locally in the western region of New York, including here in Wyoming County. Some nursing facilities have had large scale outbreaks like the one in Washington County, with a majority of the residents and many of the staff infected. Others have had just a few staff members and a few residents that have been infected, and single cases popping up here and there. And there are reasons for that, all of which we'll kind of go into as we move forward here. The statistics from the Center for Medicaid and Medicare Services, these are from November 8th, so the numbers are higher now. But as far as the nursing facilities go, long-term care, skilled nursing facilities for the most part, there have been 300,000 plus confirmed cases and another 161 plus suspect cases, which are basically those that they're pretty sure but haven't received testing back or have been unable to test for any specific reasons. So probably upward of over 500,000 cases at this point in skilled nursing facilities that we know about. Many of these cases have gone either unreported or underreported, again, just due to not so much trying to hide information as the presses like to jump on, but really just more logistical issues of trying to get data into systems that are now more robust, but weren't in the initial months of this outbreak. Again, this is going back to November 8th, but total long-term care deaths that we know about are up around 70,000, again, likely underestimated. And the big shocking statistic is that this represents 30 to 40% of the COVID deaths overall that we see, and maybe even a little bit higher percentage. We'll talk a little bit more about that and potential reasons for that. The COVID death rate overall in the general population in this country has ranged in the 1 to 3% range from what we can tell thus far. The death rate for long-term care residents has been approximately 14%, though. So that's saying that, 14% of residents who get it die from it, which is a fairly alarming statistic, but again, makes sense given what we know about the virus and the settings that they're occurring in. Just to backpedal a little bit and to go over a couple bits of terminology. One is just wanted to talk about transmission of COVID, and this is again what we know so far. Basically, it's transmitted through 3 different methods. One is called droplet, the other is called aerosol, and the other is direct surface contact. The primary one that we've been dealing with and trying to prevent is what's called droplet transmission, which are basically larger droplets that come out of the respiratory system associated with coughing, sneezing, laughing, singing, loud voices. They're heavier. They travel a short distance and drop to the ground, and they stay in the air a short time. So with these, they don't hang around in the room for hours on end. So this is really the main thrust of trying to prevent the transmission of the virus. And this relates to mask wearing and social distancing and a little less to hand washing. That's more of the solid surface transmission. But most of that has been emphasizing this prevention of droplet transmission. The next type of transmission is called aerosolization, which are basically you can think of as a very, very fine mist with small particles of respiratory secretions that are produced by, traditionally by nebulizers, which are used for breathing treatments. They can be produced by medical procedures and somewhat less, but can be part of sneezing or that kind of thing as well. The risk with these is that they float around in the air much longer, often for hours in a particular room, depending on the ventilation rate and the air turnover rate. The majority of aerosol issues are more related to healthcare settings rather than the general public setting. And again, masks do help with this. They help prevent some of the aerosolization, and the N95 or medical grade masks are what prevent uh, those smaller particles from actually getting inhaled in a medical provider. And then the final uh, part of the transmission chain is through surface contamination, which again, the research on this is evolving. I've seen anywhere from several hours to many hours of a virus staying alive on a particular surface. And again, this relates to the type of surface, the air temperature, the humidity, lots of different factors, which is where the hand washing and the glove wearing come in, and the frequent hand sanitizing. Again, this does not appear to be as big of a mode of transmission as the droplet, especially in the public in these super spreader events. But again, potentially important, but a little bit easier to deal with as far as the hand washing and keeping surfaces cleaned and that piece of it. So going back to the high death rate or mortality rate in the skilled nursing population, it's really multifactorial. One of them has been many of the residents in long-term care facilities have, in their advanced directives, they're basically, at the end of their life or getting towards that last stage of their life, and have really elected to have supportive, what we call comfort care treatment only, which means, no transfer to the hospital, no real active aggressive medical interventions, and really just letting nature take its course as it presents itself. So many residents in nursing homes already have those sorts of orders in place. So once they do become sick, whether it's the influenza or some other type of infection, like a bacterial pneumonia, urinary tract infection, or COVID, they've elected not to have any additional interventions done. So many of these residents succumb to COVID because of that desire, that comfort care type of desire. These residents are also at the highest risk when you look at all the different risk factors for getting sick from COVID. They relate to age, over 65, different medical conditions, diabetes, hypertension, anything that might immunosuppress one as far as medical therapies or the disease itself, chronic kidney disease. Most residents of nursing facilities are in a nursing facility because they're debilitated, often because of many of these specific issues. So they're at very high risk for poor outcomes when they do get infected with COVID or influenza or any other sort of infectious disease. Another issue is they live in a congregate setting, and we'll get a little bit more into that further into the conversation. But nursing facilities are congregate settings that, unlike a hospital, are set up to be like home as much as possible. So the virus tends to rapidly spread in these type of settings just because of the layout and the setup. And then the other thing they've discovered more recently is the severity of the disease may also be related to what's called the viral load. So this is where the mask wearing, even out in the public, becomes important. They've some recent studies that have shown that if you get infected with just a few virus per se, then your body has a little bit more of a chance to mount an immune response before the virus replicates in large enough numbers to overwhelm the body. So if you get infected with a large bolus of virus for whatever reason, then you are at higher risk for having a more serious case of the disease. And these residents that are in a congregate setting where people are close together and there's potential prolonged exposure are at a higher risk for getting a higher viral load to start with. And again, many of these have been addressed in nursing facilities over the course of the last 9 months, but the first several months, many of these couldn't be addressed just because of the nature of the way nursing facilities are set up. So I wanted to talk about personal protective equipment. That's the PPE that we're hearing all about. And it consists of several different stages. One is eye protection, which in the public setting, in the community setting, is not really something we've been emphasizing. This is more of a specific healthcare setting or long-term care setting issue. Use of gloves, and that's again for the contact precaution. Gowns, again, preventing yourself from getting contaminated and then moving it to another person. And finally, the mask. And of these four things, the mask is really where there's multiple levels, basically 3 levels, which I want to talk about. And these go in order of level of protection. One is just your plain cloth mask that we're emphasizing for use out in the public and in general settings. And this cloth mask prevents the droplets from getting spread out all over the place. And it does provide the wearer with some protection from inhaling the virus and the droplets themselves. A procedure mask is a type of mask that's used in a healthcare setting, which is a formally made mask that is used to prevent the wearer. It again, similar to a cloth mask, but a little bit higher level of protection against droplets, especially them going out and getting spread around, but also those coming in. Though the procedure masks are not what we call fit tested, they don't provide a tight seal, and they also aren't small enough to filter out the virus particles themselves. The highest level of protection is what we call an N95 mask, which is a sealed mask that is fitted to one's face and designed to filter out the particles, the virus particles, the droplets, and the aerosols. And that's really the highest level of protection. And these are all pertinent in the nursing facility setting depending on what's available. In an ideal setting, which would be your hospital setting where you don't have a large number of infected individuals, most hospitals have full PPE available, which is the full setup available for a limited number of patients and staff. This full PPE ideally should be changed in between each patient. The room that the patient is in should be what's called a negative pressure room, where essentially the air is being pulled out of it and filtered. So there's no air leaking out of the room into the hallway, that kind of thing. There's a good air exchange in the rooms. There's what's called an ante room, which is a separate small room outside of that room where you can change or doff or don all of your protective equipment in a safe way. And then the rooms are single. And again, this is an ideal setting where you don't have a lot of infected patients, and something that most hospitals, now that we're in a pandemic, cannot provide this level for every single infected person. I can't even come close to it. And certainly a nursing facility has no setting like this at all. The hospital setting now, basically we're setting up portable negative pressure units, which are designed to convert a regular hospital room into a negative pressure room. We're cohorting positive patients together, which means we're keeping all the positive patients in a group so that the staff can dress once, go to see different patients that are already infected and not worry about cross-contaminating. At the end of seeing those patients can then come out. The doors on the rooms are typically closed. PPE is changed frequently, and hospital settings have easy to clean surfaces that can easily be sanitized. As I alluded to before with nursing facilities, they're designed to be home-like with carpets, regular furniture, all those kind of things that are very difficult to sanitize and keep clean. The reality for long-term care nursing facility settings is typically 2 patients per room, and often, again, a home-like setting where you have carpets, et cetera, that are not easily disinfected. You have limited personal protective equipment. And again, especially early on in the pandemic, you have a congregate setting with congregate dining, congregate activity settings. frequent visitors in and out, and frequent transports outside of the facility for entertainment, healthcare, shopping, all those kind of things. So the reality for long-term care, especially when all of this hit back in the spring, was this was a setup, and they were in no way, and there was no requirement to be prepared for a pandemic of this proportion with a virus getting into a setting like this. They really, unfortunately, there was some vilification that occurred in the media and in even in the regulatory setting, and really I think was misplaced based on what the long-term care facilities had been set up for and built for. They just really were not set up for this sort of thing. Um, that has come full circle. And again, going on to some of the other issues with the nursing facilities, limited staffing, often, one RN with many CNAs, not a lot of, typically a nursing facility would have an infection control nurse who that was one small part of many jobs to take care of. Certainly no negative pressure type setting. In the smaller facilities that are full, often limited or no ability to cohort positive residents in the same area, at least initially. Limited infection control support, and then frequent staff movement between units. Nursing facilities across the country have been chronically understaffed. Often one staff member working on one unit moving to another unit to do other duties, so easy to move the virus around. The other issue that has really come to light is we have, the proprietary private facilities, and then we have public, typically county-run facilities. And there's been some differences in those, at least anecdotally, as far as their ability to be prepared. Often the proprietary facilities are freestanding, small facilities that have had limited staffing and limited access to personal protective equipment supplies, especially in the initial stages when you couldn't buy it anywhere or get a hold of it anywhere, even if you could order it. So they had less access to resources to start with. The public facilities, often the county-run facilities, at least theoretically, often had ties to the county emergency management plan and ties to what the counties had available in their emergency stocks and emergency supplies. So often had a little bit better ability to provide protective equipment to staff and residents as well. So much of this has improved since the spring and over the summer, though again, the nursing facilities are not ideally set up to manage all of this, but many of the things that have been put into place have worked and have helped to make a big difference. Though even with everything put into place in the nursing facilities, we're still seeing outbreaks, especially as the community numbers increase. So current long-term care interventions really focus on a number of areas. One is, and we've implemented these in many other settings as well, in the workplace outside of nursing facilities. These have all been proven to be helpful, but one is symptom screening, restrictions on visitors, and non-essential personnel. Again, many nursing facilities either have voluntarily or have been mandated, as they have here in New York State, to stop visitors. We'll talk a little bit more about the implication, excuse me, the implications of that. All of the staff now coming into skilled nursing facilities, there's active screening. You go in, you do a questionnaire, you get your temperature checked. If you're working more than 8 hours, you're getting it, getting screened again. All the residents have symptom monitoring in place, temperature checks a certain number of times a day, monitoring for any of the COVID type symptoms. Social distancing has been implemented within the skilled nursing facilities, movement restrictions, everything from full lockdowns into the rooms to more limited activity, going into dining areas, but dining at, one person per table. Activities have also been curtailed, but are continuing as the infections get under control. There's been a significant increase in PPE use and infection control practices based on best and the latest knowledge, which is always changing. And then plans were put into place back in the spring for PPE shortages. So many nursing facilities over the summer months that were not in active outbreak areas were able to augment their PPE supplies and get better prepared. Currently, at least here in upstate New York right now, in the non-microcluster areas, so if you're not designated a yellow, orange, or red zone, we're required to do weekly staff testing. We have no or very limited in-person visitation. Most nursing facilities are either doing outdoor visitation or through the glass type visitation, except at end of the life when somebody's death is imminent, then we are bringing people in full PPE and allowing that to occur as much as possible. Admission restrictions to new residents coming into the skilled nursing facilities. There's some requirements in place to have negative testing prior to coming in, and then you're placed on essentially a quarantine for 14 days after you come into the facility, even if you do have a negative test. The regulations that are in place for response, if you have a resident that does test positive, includes isolation and quarantine. And again, the difference between isolation and quarantine: isolation is for somebody who has a positive test, who has COVID. Quarantine are for those that may have been exposed but do not have a positive test and don't currently have COVID. So basically, if a resident tests positive, they are put on isolation, and then their potential contacts, which could be a roommate or even a hallway or a unit, are put on quarantine, where they're kept in their rooms. PPE requirements are upgraded and they're monitored. Currently here in New York State, testing then has to occur if either a staff member or a resident tests positive on the screening. All the residents and all the staff then have to be tested. And then that testing has to be repeated every 3 to 7 days until everybody comes back negative. And then once everybody is negative and you've gone through the quarantine period, then you can reopen some of the limited visiting and go back to some of the previous level of protection. So that's kind of the point where we're at right now. Like I said, even with all of these things in place in the facilities, the PPE, the staffing, it's logistically in that setting very difficult to implement these on a day-to-day basis in a way, that is at the very highest level possible if you were in more of a, healthcare hospital type setting. But the nursing facilities are really doing a great job given the circumstances, and also trying to look at the collateral because the collateral for the residents and the staff has become very real outside of getting infected with COVID and getting sick. And this is something I wanted to spend a little time on. There's not a lot of research out there yet on these impacts because we're still so early into this, but certainly anecdotal reports and what I've seen, here in the nursing facilities does support this. The first thing is the resident isolation. So we've basically taken these residents that are in a difficult situation to start with, just being in a skilled nursing facility, separating them completely from their families, except for phone and video chat type things. And then also oftentimes isolating them in their rooms and preventing them from participating in activities and dining. So we've seen increased depression in these residents. We've seen, especially in the residents that have dementia, worsening of their dementia symptoms and frank delirium, where they basically get more confused and start to have more of a downward decline. We will see if these changes with the depression and the delirium and the worsening dementia translate into increased deaths and mortality outside of the specific COVID infection. I suspect it probably will. In families, we've seen all kinds of reactions as well. Obviously, sadness, feelings of disconnection from their family, feelings of loss. certainly feelings of anger and frustration, which is often getting directed at staff and all. So lots of challenges there. Staff, we've seen a higher level of attrition. One, just because the difficulty of the work they're having to do. They're really, frontline workers who are committed to caring for residents that are positive, often without the highest level of protection for themselves. And that over time takes a huge toll on them. We've also seen attrition because staff members, family members are getting quarantined. They may have children that are getting sent home from school who then they have no daycare for and have to stay home from work. So the staffing issues are challenging to say the least. And then the latest I've seen mentioned with this last wave coming up is, quote, what we're calling PTSD in the staff who back in the spring already went through this once, with the restrictions, the deaths in the nursing homes, all of the stresses. Those things kind of let up over the summer for many regions, and now the same staff are watching that coming at them again, and I think we're seeing some very real issues with anxiety and fatigue and all the things that are associated with that kind of impending sense of doom, if you will, and what they're going to have to deal with and are currently dealing with now, but I suspect is going to get worse over the next month or two. So what is being done outside of our infection control issues is one, we're trying to, get the residents out within the facility for activities as much as possible with the activities staff doing as much as we can with social distancing, masking, and things as safely as possible. We're doing a lot of things within the room, FaceTime, video chats, programs like that. We're working with the therapies, physical therapy, speech therapy, occupational therapy, trying to get as much done either in the room or even on a limited basis in the therapy settings themselves. Again, as I mentioned, doing through the glass visits as often as possible. And then when weather was permitting, the outdoor visits. We're also working with, the social workers are doing a great job with the counseling aspect of it, trying to work with residents. And then we're trying to use telehealth from a telepsychiatry standpoint. We're seeing increased use in that. And certainly, as far as the medical care for these residents, many of them can't go out to get their normal specialty visits done. Telehealth has been very helpful with that, and we're working on that level to get that done. So what's next? Well, hopefully within the next couple of weeks, we'll be starting to see the vaccine trickling in, and certainly the long-term care facility staff and residents are going to be part of that first wave of vaccinating. So hopefully over the next couple of months, we'll get the staff and the population vaccinated so we can really start to return to some level of normalcy for them and as a community. The effectiveness of the vaccine in the elderly, again, there's not a lot of data out there yet as far as, trials. Older people with influenza vaccine. When I say older, I'm really talking about the old, um, tend not to have a robust immune response to things like influenza vaccine and such. So I'm not sure what the case will be with the coronavirus vaccine, but it certainly will help regardless. So that's really all that I wanted to cover at this point in time. A lot of evolving issues going on in the long-term care setting, and everybody's working as hard as they can really to help keep our residents and staff protected. So I would open it up to any questions at this point. If anybody has anything particular, I would be happy to entertain that.
So I'm sure some people will have some questions. Please go ahead and put them right in the chat. And I have a couple myself, Greg. So we talked a little bit about PPE. How much of a struggle has it been for our older citizens to get used to wearing masks? Are there any complications with that? Can you talk a little bit about that?
Yes, that's actually a very good point to bring up, and I really didn't touch on, but that's also one of the other significant challenges in the setting is many of the residents from a medical standpoint have pulmonary and lung issues, and having a mask on is very difficult for them, and many of them can't wear masks because of medical issues. Many of them from a cognitive standpoint cannot keep a mask on just because they will pull it off, they don't understand. So many of the residents aren't wearing any PPE like we normally would do going out in the public just because they can't. So that's another risk factor in the long-term care setting for transmission. That's a very, very good point.
Yeah, I have seen that it's been difficult. My mom is in a facility, and she just she's not comfortable wearing a mask. And so the very few times that I've been able to see her, the mask comes right down when I talk to her. When um, I've taken her to the doctor twice since this started, and no matter how many times I remind her how important it is, it just, it doesn't seem real to her. It doesn't seem real.
No, no, and that I think comes, partly from being in that setting where it just it's hard to really conceptualize, the bigger impact of this when you're not out in it. But the other thing on a more positive note that I've certainly seen with this, both among the residents and the staff, is the strength of the human spirit and their
Mm.
ability in the face of significant suffering, probably, one of the groups with the highest level of suffering from this pandemic to rise to the occasion and really, have a positive attitude. And that's been inspiring to see, both amongst
Right.
the residents and the staff.
Yep. Agreed. Please don't hesitate to ask any questions that you might have. I did have another question. What is it that families can do? There are a lot of us who have family members who are in a facility, whether it's assisted living or a nursing home. What can we do to help staff?
Hmm. Well, certainly the first thing would be to understand that the staff are, in the same boat as everybody, and try and, you know, be, I guess, just try and cooperate with them with what they're trying to do and understand that, they are feeling the same way about the restrictions, but just have to deal with them. So try to be kind and understanding, even in spite of your own frustration and grief, with them. That would be, I would say, the biggest thing, and just really try to work with them on that. And also any kind of support that you can provide. And many of the families do this already, even without the pandemic and the COVID, whether it's, candy or any kind of thing that you might want to provide just as a little acknowledgement of what the staff's going through. Those do make a big difference, even if the staff doesn't get a chance to acknowledge it specifically. It means a lot to the staff as it does to the residents to know that they are still connected and we are out here, supporting them in what they're doing.
And I know there are a lot of restrictions as far as that goes. You wouldn't want to take in anything that was homemade, unfortunately, for staff. Is that correct or no?
It would really depend on the particular facility, and I would check with the nursing home administration to see what they're allowing and not, because there's definitely some variability in that.
Okay. Okay, I have a question from Tamara Walston. She said, what kind of timeline do you think there will be for the vaccine effectiveness as far as being able to visit people in long-term care facilities again?
Oh, that's a really good question that I don't think there's an answer to yet. Certainly, we're going to have, the staff and the residents vaccinated part of the first wave of vaccination, which will provide them protection. Uh, the question is going to be then, and again, this will be a regulatory issue on the state end. If they feel that the staff and the residents have been properly and adequately vaccinated, will we then allow people who are not vaccinated to come into the facilities? Because theoretically, they should not offer a major risk to the residents and staff once the residents or staff are vaccinated. So, ideally, maybe a couple of months we can start to open things up. It's going to be probably, I would say, 6 months before we see widespread vaccination, in the full community, which would then allow things to open up without any issue. But I think it'll be a stepwise approach and a graduated approach, starting maybe with coming in with protective measures, face mask, that kind of thing on after everybody in the facilities themselves has been vaccinated, and on a limited number, limited time, but gradually opening up.
Lorraine had a question as well. She asked, if a resident tests positive, what are the legalities of notifying roommates and close staff?
That's again a challenging question. And with the public health emergency declared, many of the restrictions that normally would be on information sharing are loosened up. So again, many of those decisions are being made on a case by case basis. And the basic guiding principle is really what's needing to be done to protect to residents and staff directly, and is any sort of release of specific information being utilized that way. But I know the facilities are being really careful about that. And again, as far as staff and administration knowing about a resident's positive, that is generally fairly straightforward. As far as other residents being notified, that generally isn't necessary, and unless there's a particular reason for a particular resident to know. But again, that's probably would be not information that would be readily given out. Providing another resident's information to a resident, basically what we'd be doing is telling a quarantine person or a potential contact that you've been exposed to somebody who's positive, but we would not tell them who that particular person is.
Right. Diane Wilkinson said, my dad is in the Wyoming County skilled nursing facility. The staff has been doing an excellent job. That's good news.
Good, thank you. I will pass that on.
And I agree. I think there are so many healthcare providers that are doing the very best that they can, and they've really stepped up to, in this extraordinary circumstance.
Yep, I would agree. And previously back, in the spring and summer, the nursing homes were significantly impacted upstate here, where there really wasn't a lot of disease in the community. And so the nursing facilities were really, from my perspective, the front line of the initial wave upstate here anyways, not speaking to other parts of the state or the country. But now, they have the double burden of, the staff, especially dealing with it in the nursing facility, but now out in the community, at home, the schools, their children, their spouses. So there's a whole nother layer added on.
Do you see any difference in how things have worked out for assisted living versus skilled nursing facilities?
There, again, anecdotally, there does not seem to have been the wide scale outbreaks, at least I'm speaking upstate regionally here, up until recently in assisted living versus the skilled nursing facilities. But again, there are examples, where there have been outbreaks in assisted living facilities more recently regionally. So that's changing. I think, the mortality and high morbidity rates are probably less in the assisted living facilities, just because those residents tend to be a little bit healthier than those in the long-term care facilities.
Are there any other questions for Dr. Collins? Okay, it doesn't look like there is. I know that you are so very busy in your calling right now, not only your clinical practice, but your work with the skilled nursing facility. So I want to thank you again for taking the time out to do this, to prepare and to come on today. Thank you
Certainly.
so
Yeah,
much.
my pleasure. And I appreciate everybody taking the time out to listen as well. Thank you.
So again, thank you everyone for attending the webinar today. You can remember to click on the webinar session evaluation page that's included in your Zoom invite. Next week, we continue the series with a new topic, treatment of COVID-19 and other infectious diseases of public health importance. Two physicians from the U of R Medical Center, Dr. Daniela DeMarco and Dr. David Dobrzinski will be here. So we look forward to that. I hope everyone has a great day and stay safe.